We have two categories that we're going to look at today: substance-related and addictive disorders and neurocognitive disorders. Our first category is one that you're going to see a lot, and you're going to see it co-occurring with other diagnoses: the substance-related and addictive disorders. So in this category, we have 10 separate classes of drugs, not always fully distinct, but they're there. We're going to note that all drugs that are taken in excess have in common the direct activation of the brain reward system, and that this is intense enough that other activities of daily living might be neglected. Typically, feelings of pleasure or being high are being produced when these different drugs are being utilized. We note that people who have lower levels of self-control might be particularly predisposed to develop the substance use disorders. And a lot of this is related to that brain activation. So we're not necessarily looking at the specifics of what's happening with that specific substance, but we're looking at the way the brain is functioning and the way the brain is changed when this takes place. And that's why we're also including some other items such as gambling. So gambling is obviously not a substance, but it is an addictive disorder. And we're seeing that the brain reward systems that are triggered with other substances are also being triggered when we look at gambling. So it's really important that we're looking at that part, not just, is this a drug? Is this something that they're doing for X, Y, and Z reason? We're looking at the way the brain reward system is being triggered. We have two different distinct categories within this: substance use and substance induced. The induced is going to be things like intoxication and withdrawal. Not all 10 of the classes of drugs have both of these, but most of them do. We'll look at a couple of exceptions. So our substance use disorders are going to start on page 543 of the DSM-5 TR. And we're going to be seeing the cluster of cognitive, behavioral, and physiological symptoms. Substance use is going to be applied to all 10 classes except for caffeine. So we can have some substance-induced activities with caffeine, but not substance use. And again, we're looking at the way that the brain is functioning. So we're looking at underlying changes in brain circuits that might persist after the use of that substance has been utilized. Whether it's 2 hours later, 2 months later, we're looking for some of those patterns of changes to the brain. We have a couple of sets of criteria. The first grouping is going to look at the impaired control over the substance use. So for example, we're going to see activities such as larger amounts of the substance is needed over time to produce the same effect. We might see the desire to cut down or regulate, but not the ability to do so. And we might see a lot of time being spent obtaining the substance, using the substance, or recovering from that substance use. Our second level of criteria is looking at the social impairment. So here we might see something like a failure to perform major obligations at work, or maybe at home. Maybe they're not able to take care of the kids in the home, whatever that might look like. So this is going to have a continued use despite those social or interpersonal issues. Our third set of criteria is going to look at risky use. So here we might see something like taking substances even if it's hazardous, or that a current issue is being exacerbated or even caused by the use of that substance. And then last, we're going to have the pharmacological issues. So that might be where tolerance or withdrawal comes in. If the person is having those pharmacological symptoms while they are under medical care, that does not count for the substance use disorder. And here we're going to use the code that applies to the class of substances, but then we're going to write down and record the name of the specific substance that is being used. So make sure you make a note of that it's going to look different for each different specific substance, even though the code is going to be the same. The other section of this, and again, we're not going to look at every disorder because the criteria are basically the same um, between all the substance use diagnoses and all the substance-induced diagnoses. It's just going to have a couple small changes based on that specific drug. So our substance-induced disorders, you might take a look at the first one with alcohol intoxication on page 561 if you need example. But this is where we're looking at intoxication, withdrawal, and other substance or medication-induced mental disorders. Intoxication is where we have the development of a reversible substance-specific syndrome due to the recent ingestion of the substance. There will likely be a clinically significant and problematic behavioral or psychological changes, such as that mood lability, that huge mood swings, maybe impaired judgment, and it is not attributed to a different medical condition. One thing to note is that this category will not apply for tobacco. The criteria for withdrawal in substance-specific sections is going to look at essential features, and it's going to have examples of problematic behavioral changes due to cessation, reduction of use, clinical distress or impairment, and again, not due to another medical or mental disorder. And once again, just like the substance use, we're going to use the code for the class of substances, but we're going to record the name of the specific substance that that person is using. Substance or medication-induced mental disorders is a little bit different. It could be very severe, though. Usually that's a temporary issue, but it could sometimes persist in the central nervous system. Sometimes this will develop in the context of the different effects of the substances of abuse, the different medications, or several different toxins. This could be induced by the 10 classes that produce substance use or by a variety of other medications used in medical treatment. So I think with all of these, it's important to note that medications used under the care of a doctor could also cause one of these diagnoses if they're being misused. So typically, if a person might start, a very common one that we hear is someone has a pain medication after surgery, and then they feel like even after they supposedly do not need that anymore, they continue to use it because they continue to have pain, and then they develop a substance use disorder. Each substance-induced mental disorder is described in the related chapters. So in each of the different categories, you're going to see something like depressive disorders induced by a medication, right? So it's something that cannot be explained by an independent mental condition. This is often developed in the context of intoxication or withdrawal. And again, we can see this with prescribed or over-the-counter drugs as well. We do have that one so far, just the one, for the non-substance related disorders that fit into those addictive categories. Gambling disorder is on page 661. Here we have that persistent and recurrent problematic gambling behavior leading to a significant impairment or distress. Fairly low prevalence, usually develops in adolescence or early adulthood, and usually it takes a couple of years to really develop that over time. So again, we're looking at this gambling disorder because of the way the brain's reward systems are being activated, and that is so similar to what we see with substance use disorders. I'm kind of expecting that in the next couple years, a couple other things will be added. There was some discussions about adding a couple others, but this is the only one that met the criteria so far. Our second section for today is looking at neurocognitive disorders. So this is going to encompass a group of disorders in which the primary clinical deficit is in cognitive function, and this is acquired rather than developmental. So this is not something that we're going to see starting in birth or early life. This is going to be a change in a previous level of functioning, a decline in that previous level of functioning. Typically, this is fairly short term and it typically does resolve. So something that we see fairly often might be people have a decline, maybe they have a UTI and their cognitive abilities decline, and they go into the hospital and then they get treatment and then it stabilizes, they return to their normal level of functioning, the diagnosis goes away, and they're back to their normal functioning. So short term is more what we typically see with these. One of the other things that's a little bit unique with this is that we usually know why they happen, and it's usually medically oriented. So we're going to say, oh, this is because of X, Y, and Z. This is because of Parkinson's. This is because of the misuse of a prescribed substance. Lots of different variations. Sorry, my cat's having a little fun in the background. So we're going to usually know why it happened. And again, it's usually going to resolve itself over time. The DSM will recognize a mild neurological disorder as well. So you can see the criteria based on the different cognitive domains on page 669. The one that I think is the most common, and again, you're mostly going to see this if you're working in a medical setting, is delirium. So our essential feature here is the disturbance of attention or awareness that is accompanied by a change in baseline cognition. And it is not better explained by a pre-existing or an evolving neurocognitive disorder. So usually we're going to see something like that disturbance in attention, that people can't focus, they can't maintain that focus, they can't shift attention, their attention is wandering, or they're very easily distracted. And again, this is usually happening over a short period of time, and it tends to fluctuate. So they might be fine in the morning, but not at night. They might be fine at 10 o'clock, but 11 o'clock, they have lost their ability to focus. And because this is usually related to a medical substance, medication, or toxin, we're going to code the delirium as being caused by whichever one it is. And we're usually going to see that change and be resolved in a relatively short period of time. In addition to that disturbance of attention or awareness, there's going to be at least one other area of change. So that could be memory, it could be learning, it could be a change in language, it could be a motor disturbance. Lots of different things can happen. There's often an association with a disturbance in the sleep-wake cycle. People might be very emotional. But again, the two things that I think are really important is this is going to be mostly with hospitalized older adults, and most people will have a full recovery. So this is not going to be a long-term or permanent diagnosis. We're also going to have other specified and unspecified as categories of delirium. This is where we might not know exactly why, or we're choosing not to specify the reason. Maybe, again, there's just not enough information. So you might not see that quite as often. Usually we do know the etiology, the why it happened, but not necessarily always. Mild and major neurocognitive disorders are also in this category, where we have that spectrum of cognitive and functional impairment. And it's a little bit challenging because this is on a continuum. It's not as clear as if you have 3, then it's going to be major. If you only have 1, it's going to be mild. It's a little bit more vague than that. Our major neurocognitive disorder is going to correspond to what in the DSM-4 called dementia. So it changed a little bit from the DSM-4 to the 5. Here again, we're usually going to know why, and we're going to use those labels as specifiers to show what the cause of this was. Prevalence is going to vary a lot due to the age and what caused that neurocognitive disorder. So use your book, make sure you're looking at those different criteria, and that's going to help you more than anything else when you're looking at this category. And that is all for our discussion today. Thank you very much. See you next time.